Good afternoon, ladies and gentlemen. Welcome to this afternoon's special edition of Winning Against Cancer Public Symposium, organized by National University Cancer Institute, Singapore, also known as NCIS. My name is Annie, and I'm your MC for this afternoon. And before we start, please be informed that there will be a photographer taking pictures of these events for use of NUHS as well as NCIS for publicity purpose in corporate materials such as brochures, social media sites, as well as the mass media. A videographer will also be engaged in recording the presentation, and the presentation will be put up in NCIS YouTube channel next week. And without further ado, let's start the program. Let's first invite Dr. Yvonne Ang, consultant from the Department of Hematology Oncology, NCIS, to give a welcome address. Dr. Ang, please.
Thanks very much for that kind introduction. I'm going to keep this quite short and sweet. So my name is Yvonne. I'm a medical oncologist from the National University Cancer Institute of Singapore. Thank you very much, everyone who's attending today, for spending your precious Saturdays with us. Perhaps before I start, could I ask how many of you have experienced either yourselves or family and friends who have, gone through cancer or gone through cancer treatment and the journey? Yeah, so many people here have been exposed to this, and I think having exposed to this, having been exposed to cancer care, you probably have come across two things. First of all, that it really is a team effort. People who are newly diagnosed with cancer might first come in thinking that the main person that they're going to see and rely on is really their medical oncologist, the person like myself who is deciding the cancer treatment, giving chemotherapy. But I think many of you, having been through the system, probably know that this is not the case. We really work in a very close-knit team of colleagues, multidisciplinary colleagues. You might first be diagnosed by someone from a doctor from a non-oncology specialty. You might come in and see your oncologist, but also be referred on, also have been helped along in your journey by your social worker who, helps you to navigate the social and financial challenges of having cancer. You might come into contact with people like the dietitian who might help to improve your appetite and your oral intake, the physiotherapist and the occupational therapist who help you to keep your strength up, help you to make modifications in the home. So today what we're hoping to do through this series of talks is really to expose you, first of all, to the team that looks after cancer patients, ranging from the medical social worker. So later, Ms. Tarina Tan, one of our senior senior principal medical social worker, will be speaking to us about the role of a social worker in accompanying cancer patients through their cancer journey. We also have our head and senior consultant of the Palliative Care and Supportive Program at Alexandra Hospital, as well as a member of our Division of Palliative Care at NCIS, Dr. Yong Woon Chai, who's going to be sharing a bit more about palliative care. And then I'll be speaking as well about clinical trials. So we're hoping to speak to you guys a little bit about, areas that you may not have so much direct knowledge of before entering a cancer journey, but actually form important parts of this walk. The second thing is, I think that you would have known, also walking with someone through a cancer journey, is that, aside from meeting many different people, there are also many different areas, many different services that you may need to access. So including things that may not be so familiar to people on the street, things like, clinical trials, things like palliative care. So we hope to introduce that a little more to you guys today. So I think I'll keep this short. I won't go on any further, but perhaps we can move on to the speakers, and I hope you enjoyed the talks and be very happy to answer any questions afterwards. Thank you.
Thank you, Dr. Ang. May we invite our very first speaker, Ms. Tarina Tan. She's the Principal Medical Social Worker with the Department of Medical Social Work at the National University Hospital. She will share more about the topic titled, Getting the Support That You Will Need, the Role of a Medical Social Worker During Your Cancer Journey. Let's welcome Ms. Tan.
Hello, good afternoon, everybody. Okay, let's wait for a minute for the slides to be up. Okay, good afternoon. Thank you for taking time out to come here. As you all come and listen to this talk, I hope that you all don't just listen for yourselves, but you will be ambassadors of the information here to share to other people outside, especially for social work staff, okay? Very important. Yeah. Okay, my colleagues are staring at me because it means more work for them, but it's important. Okay, so to start off, I think cancer journey is a very difficult one. Right, it doesn't start at the point when you see the medical oncologist. I think like what Dr. Ang said, right? Even before you see the oncologist, you find a lump, you start getting stressed already. Correct? So you start thinking about it, and if we are brave enough, we'll see a doctor quickly. But I know of many patients who will sit on it for a while. And during that period of time, a lot of worries start coming in. And being Singaporeans, people still believe that healthcare is very expensive. And the suspicion of cancer is that, wow, super expensive treatment, I cannot afford it. Right? People still think that you cannot get sick in Singapore. Okay, but I hope that from today's talk, you realize that this is not true. There are resources available. Okay, it doesn't cover everything, but it's enough to help you through your cancer journey. Okay, so to start off, I think social workers, right, MSWs, we're called medical social workers. I think some patients joke, oh, you are money spinning workers, right? They always associate us with money. Okay, but you will learn through this presentation that we do more than just access financial support for people lah. Okay, but I'll start with the most important thing first, financial support. I think just a note that so in social work that we practice, we believe that cancer doesn't just affect one person. It affects the entire family. And whoever knows this person, it can be your friends, it can be your bros, it can be your sisters that you chose for yourself. And these are people that all get affected when someone gets a cancer diagnosis. It's like a big pool of water. Okay, if you drop a droplet right in one corner of the pool, eventually the ripple will float to the rest of the pool, and everybody gets affected. Of course, the closer you are, the bigger the impact, right? But eventually, everybody gets affected. And the work that we do in social work, we believe a lot in the systems perspective, where we do not see an individual only, but we believe that everybody is part of a bigger system. That's why the services that we provide is not just for one person. It's but for the family as well, and for whoever is actually affected by the cancer diagnosis. Okay, so starting off, let's go into the financial things, a very practical one. A lot of people worry about the financial aspects of cancer treatment. We always wonder, very expensive lah, how lah, will I die, things like that, right? And adding on to that, there's also concern that I cannot work now, what's going to happen? Everybody worries about being a burden on their families. Okay, we have a lot of good parents here, we have a lot of good family members who do not want to burden their family members. But actually in Singapore, most Singaporeans and PRs, we actually have a lot more resources than we think. Okay, essentially all of us have MediSave. Okay, only how much only lah, right? If you work longer, you have more. You work lesser, you have less. So MediSave, you can actually utilize your immediate family's MediSave. Husbands, wives, children, parents, if needed. Okay, and all of us also have MediShield. Okay, MediShield is, usually we tell patients, simply put, is government's insurance. Government give everybody that insurance. And every single Singaporean citizen and PRs have this insurance. Okay, so some of us are actually have actually purchased private medical insurance before, so we have enhanced plans. Okay, so actually a lot of people say, I know I have this insurance, but they do not know that these things can be used to pay for cancer treatment. Okay, I remember many years ago, this lady came to my room. She was, I met this lady, she's in her 50s, 3 children, and she has committed her whole life to take care of the family. So she's a homemaker, doesn't have a lot of MediSave. Husband has been sole income earner for a long time until recently when the second daughter started working, just 1 year, fresh out of uni. So eldest son is still studying because guys have to serve NS, right? The youngest one is in poly, plan to go NS and then study again. So the family situation has gotten a little bit better. Okay, and then she got diagnosed with cancer. She came in very, very worried. She came in with her husband and her daughter. So after looking through everything, the things that she has, I said, hey, you have private medical insurance. And after you work out everything, essentially, she didn't have to pay a lot of cash, only had to pay for consultations and the investigations. And she was so grateful. When they left the room, they said, thank you, like social worker, you helped us a lot. I said, I didn't do anything for you. You should thank your husband, hug him and say, thank you for being a good husband, because he bought the insurance for you in your younger days. So sometimes people have those resources, but they are not sure how to use it. So even though social workers are available to point you the direction, say this can be used, we will explain a little bit, but we are not your insurance agents. We will still be asking you to go back and confirm with your insurance agents. After all, you all bought from them, they earn money from you, and we make them work for their money lah. Okay? Go and ask them, and keep on asking until you understand. Okay, this is the process what we call empowerment. Because when you have that knowledge, you feel more assured. You understand, you feel more assured. Okay, don't be paiseh. If you're paiseh, you end up struggling a little bit on your own. So ask until you understand, because this is what you have. And when you understand exactly how things work, that part is no longer a worry for you, right? Because we know that certainty is there. Okay, so these are the resources that everybody has. And but there are some changes in cancer funding last year, right? Before that it was quite complicated already, then it got even more challenging. I think if you all have read the news, you have followed the news, MOH came up with a cancer drug list where they now have very specific deductions for Medisave and Medishield for certain cancer drugs for certain types of cancer. Example, this is all available on the MOH website if you're interested to go and find out more for those of you. This particular medication for ladies with breast cancer, Medishield can cover 800 a month, Medisave 600, and then you see the term MAF. It stands for Medication Assistance Fund. I'll talk a little bit more about it later. Okay, another example, a particular drug that can help both leukemia and lymphoma patients. So there are certain cancer drugs that helps different cancer types. Different deductions, you can see. All right, different deductions based on that. So it's very specific, and there are clinical indicators as well. Okay, for example, you see the last part where it's combined with a different drug, there's no MAF. Okay, although here listed no MAF, it doesn't mean we cannot appeal, because we do have case-by-case appeals. When the MAF listing is there, don't have to do anything. It's an automatic deduction subsidy that comes into the cancer payment part. Okay, but for those without the MAF, if need be, we can actually do case-by-case appeals for it. Okay, so what's MAF? We talk about it. It's Medication Assistance Fund. Are there certain criteria for it? Yes. Okay, the subsidy is automatic and it's according to your household income. Okay, auto calculation, don't have to submit any documents or anything. It's already in your based on your Medishield Life deduction. Okay, and for this funding, actually, previously, PRs didn't get any assistance from Medication Assistance Fund, but I think they have opened up already. PRs do get some help for it. Okay, so supposing you have all these resources, but you still need help, then how? Final safety net, Medifund. Okay, Medifund is actually the government's endowment fund that is used to pay for, can be used to pay for treatment that is already after all the deduction, right? Medisave, Medishield, insurance, MAF, still got cash component that I have difficulty with. Okay, do not fret, do not worry. We can tap on Medifund to help with your medical bills. Okay, the criteria are there. It's for Singaporean citizens. PRs, there's a different fund that we tap on. You have to be a subsidized patient, of course, and you have to be seeking treatment at an institution approved that can use Medifund. NUH can. Okay, NUH can. And of course, I think, look at the assessment process. It actually looks into the constitution of the family. Okay, some people think that if I have savings, cannot. No, it depends on how much savings you have. It depends on what you need to support as well. Some people say, my income is this level, sure cannot qualify. I say, it's not about qualification or eligibility. We actually look at affordability. One simple example that I always say is that if someone earns $5,000, sounds like salary not bad, huh? Okay, to these days very low because cost of living very high. Maybe earn $8,000. It sounds like it's quite a lot, but $8,000 supporting a family of 3 and supporting a family of 5 is different. Out of the 5, if your kids are very young, milk powder, all this very expensive, right? Diapers, additional cost, very high cost as well. Or you're supporting teenagers who has very, very healthy appetites and they eat a lot more than the average person, right? So so your income is actually impacted by the result, by what you have to spend on. And that's why the assessment talks about considering your family situation, social, health, financial. Okay? So aside from that, there are actually a lot of partners in the community, right, who are also available to provide support for cancer patients. These are just a few of them, okay, in various ways. And I think the message sent out to cancer patients, you really are not alone. There are a lot of people, many, many helping hands available, okay, for financial part. Okay, now that we settled the financial thing that everybody is very concerned about, let's move on to other things that medical social workers do beyond just spending money. Okay, oh sorry, this part I forgot. Aside from cancer treatment, right, we also look at daily expenses. Because we cannot give you the best drug, right, access to it, but you're not eating well because you have not enough money for your daily expenses. So these are things that we look at. And we actually help patients to kind of work out with their employers also some things, some of the resources they already have. For instance, if a patient comes to me and they have leukemia, usually they go through bone marrow transplant, right? We know straight away that it's 1.5 years that they probably will not be going back to work. Okay, but again, it doesn't mean that once you got cancer, cannot work. It also depends on what kind of work you are doing. I actually have patients who was working through the whole time because he happens to be in IT line where he can work away from the office. And even some other patients on chemo, they were working as well. There's a female patient that I know. She's office-based job, yes. She does accounts and all that, but she would actually come in on chemo Friday afternoon. Okay, and then she will have a chemo Friday afternoon. She will rest over the weekend, and then Monday she can go back to work because she feels better by Monday. So of course, this was a pattern that she realized. On some days where she's not just take Monday off, so actually she was working all throughout her cancer treatment. Okay, so it depends. So don't be a rush to quit your job. Of course you can if you decide you want to focus on other things, but it may not be. Okay, I think one thing that we always encourage people is go and talk to your employers and see what they can do for you. I've heard from many patients, very good employers who actually changed their jobs to be something that they can actually cope. Like there was a guy who was actually in those, I think he was working in an area where he was doing a lot of cleaning stuff that was very toxic. When he go to cancer treatment, his boss actually moved him to the store where he didn't have to touch all those toxic things so that he could support him and he still continues working. Okay. Supposing physically you really cannot tahan, cannot work already, very, very tired. Okay, then we will say discuss with our company about how much hospitalization leave do you have. Okay, and then we will plan, like end of the year, 60 days, another 60 days the following year, right? Calendar year versus financial year. We also will encourage people to ask your bosses about prolonged hospitalization leave. Different companies have different policies. Some have a 6 months, you still get full pay, 6 months half pay, 6 months no pay, but you're still employed. Some companies 3 plus 3 plus 3. So don't be in a hurry to quit, but go ahead and find out first what is available, because then it won't be so scary. Right? Because patients just come and say, I cannot work anymore. I say, wait. Let's figure that part out first. Okay? So we always look at those resources that can help your daily expenses. Of course, savings is something that if you already have, is what you tap on. Okay? Again, community resources. ComCare is the government's assistance for people, but I will be very realistic to tell people that it doesn't replace your income. It doesn't replace whatever you have been earning. They help with very basic needs. So there are other community resources that we tap on. It's kind of a many helping hands approach to ensure that there's enough. But undoubtedly, there's always a need for certain levels of adjustment as well. Okay? Actually, there's one thing that I didn't put here. I put etc. there because there could be other resources that we tap on, like food rations. So really many, many helping hands for different things. There's one thing that I didn't put in here, but I think that's something that a lot of people are very cautious about. But I've seen a lot of patients getting very good support from family and friends. Okay, I think recently we heard of a patient who is actually working here on treatment. His landlord actually waived off his rental for many, many months to allow him to stay here for treatment. And the landlord was actually supporting him, very, very kind. And that's not the only case. I have another single elderly gentleman, right, who tells me he has 2 grandsons, but grandson different name. I was a different surname. I was a bit strange. Then I discovered that the grandsons are actually his neighbors. He and his wife used to watch over these 2 young children, these 2 kids when they were young. And when he needed people to bring him for medical appointments, the 2 boys, right, who are, I think one in NS and one in, I think studying, I don't know, IT or poly, they took turns to bring him for his medical appointments. So I think there's a lot of support in the community as well that we may not be aware of. Okay, and people always feel bad about asking help from family. I said, not ask, they give, you take. Okay, no need to ask, they give, you just take. Because I think sometimes it actually helps those people as well because they feel that they can do something for you. Okay, if you matter to them so much, obviously you have impacted their lives, and being able to have that reciprocity is something good for them. Okay? So after all the money issues, I think this is a very important part in cancer care that we often have to talk about, which is the care support. Okay, I think these days due to advanced medicine and all that, we are seeing patients who are much older being able to go for cancer treatment. I mean, I am in hospital for many, many years. I think in the early days when someone is a bit older, usually most likely no treatment because very difficult for them, right? But these days I'm seeing older adults being able to have the opportunity to even fight the cancer. Okay, we have a Jerry Onco specialist team that actually provides that kind of care for that population of adults. Okay, so definitely care arrangement, care planning is very important because I think we all know that cancer, before I think the advancements, right, coming in, that new drugs will have lesser side effects. That's very exciting to know, and I already see some of it happening already. But the side effects are still there. Okay, if we are a little bit younger, it hits us in a bad way. But if you're a bit older and already not so good functionally, it hits you even. I think that the effect is a lot worse lah. So I think pre-planning about arrangements and such is actually good rather than wait till things happen and then the family panics. Right? Everybody panics and they start scrambling. So the considerations that we have, the considerations include, I think we talk about two things only: functional status, how that person is like, how they would be with the treatment. So social workers, we work very closely with our doctors, pharmacies to kind of understand with this treatment, what's the side effect like, how will it impact the person. Then we can plan together with the family. We also look at certain treatments that require specific care. For example, there are patients who, radiotherapy is something that people have to come every day. Although it's very short time, half an hour, right, back to back. But if you think about it, most people, family members, very hard to bring them every day, right, for treatment. So this is something we have to look into arrangements for. Another thing could be patients who go to surgery. They may have 2 drains when they go home. Okay, the hospital doesn't want to keep them in because they just had surgery. Or hospital, we are scared to get infection, right? Going home to recover is good. But with 2 drains, how can they cope? We have to make sure that they can cope. Then we have some people who live on their own. Simple things like after surgery, right? Before surgery, we tell them that if you have plates and cupboards on the high cupboard, please bring everything down because you can't stretch after surgery. So these are the kind of very down-to-earth things that we actually, the nurses will reinforce with them. We will also talk to them about it to prepare so that when things really happen, they are in control, they feel prepared, they don't get anxious, they don't panic. Okay, so care arrangement is a big part of the work that we do as well. And what are the resources available? Again, family and friends. Okay, the community that we are part of. Okay, look at what you have first, and we'll kind of explore with you guys and negotiate along. And sometimes we just strategize with them. Like we have people who want to be supportive to their spouses. I want to be there with her for chemo every day. But Singaporeans are annual leave not a lot, right? If you're fortunate enough to be work from home, do your work offline, of course, very good, you can be here all the time. But realistically, we might kind of strategize with them to keep your leave for medical appointments because very important, right? You try to arrange things in one day. But chemotherapy, usually when they come for chemo treatment, they are feeling a little bit better, so they come on their own. You just come and pick her up or pick him up at the end of the day. That way they save their leave and things like that, arrange the timing accordingly. This one involves negotiation. The hospital is a bit hard to promise because there's a lot of patients. But let's look and see what we can do together. So these are all discussions that we work on things together collaboratively to get things sorted out. Okay? And then all the other community services. Okay, you will see some of them, there's transport services provided. There's also day centers that some of our patients actually go to because there's no caregiver at home. Some of these day centers are not just because you need physical caregiving. They also provide emotional care because you stay at home, nothing to do, right? You think and think and think and you worry and worry and worry. But when you go to the day center, there's engagement with people. They talk about things, they encourage each other along. You actually are occupied and meaningful occupied. And I think when your mood is better, it also helps in your whole cancer journey. Okay? Okay, and lastly, the psycho-emotional support in the cancer journey. Okay, this is the big part of the work that we do actually. A lot of the things that we talk about, etc. Coping with diagnosis, right? Cancer still is thought of as a life-limiting illness. I look forward to the day where people will see cancer as a chronic disease, totally curable, right? We deal with the losses. When you get cancer, right, you don't just lose your health. Your sense of safety of the world just disappears. Right? Even those who have recovered fought cancer, it's still very scary. I have a patient who, after 10 over years of recovering from her cancer treatment, she says every time she has an appointment only once a year, the week before that appointment, right, the whole week, right, she cannot sleep one. Because the worry is always there that you'll come back, right? So it's a very real anxiety. We don't just deal with losses, then also losses of income, losses of roles, right? It can be, I was sole breadwinner, now I cannot be sole breadwinner. Logically, everybody knows that, yeah, it's not because I don't want, but I cannot. But here, people just feel guilty. We have a lot of good parents among us, a lot of good husbands and wives among us who feel like they're letting down their families. So those are things that we address. We don't just deal with losses, we celebrate wins. Okay, I remember a patient of mine, right, had a stoma bag because of colorectal cancer. Then he was able to put the stoma back. One day he popped into my room, right, so happily and said, Tarina, I was able to pass motion naturally. For the first time in my life, right, people got so happy that they can ship normally. But I think these are things that we take for granted because he hadn't been able to for the past 6 months. Okay, so we celebrate the wins because you realize that when people get hit with something like that, right, most people just wake up and think, I don't sweat the small stuff anymore. Things I used to think was a very big deal, fight over this, quarrel over that, are not important. Let's focus on life. And this is a win. This is something that they take with them. Okay, adjustments to roles, identity, mental health issues, spiritual struggles. We don't talk about religion to people, but if they do have religious faith, we will encourage them to go back to their religious leaders to find solace and comfort from there. But spirituality is a lot about meaning making. The why me question. Increasingly, we see a lot of younger patients, and I think that's a question that a lot of people ask. Okay, and sometimes even elderly parents will come and say, why does it have to be my daughter? Why not me? I'm already so old. So these are the issues that we address with them. We do mediation amongst family members, crisis intervention as well, because tempers are high, there could be certain marital conflict, there could be certain family violence within the family, or people may want to just, in a moment of anxiety, kind of want to just end their life. So these are things that we also intervene. And of course, I think for some of our patients who have fought the good fight, end-of-life support, and in that whole process, right, caregiver support as well. Remember we said cancer affects everybody. And of course, bereavement, the after the fact. Okay? So how do we do it? Counseling, family work, crisis intervention, support group. We have a support group for children. Children are the unseen group that adults always say, no need to tell them they don't know one. Actually, they know. They know. So I think we see that this was a gap. We often work with parents on how we can break the news to the children. Okay, children, they said, but they are so young, how would they understand? 6-year-old, we will speak a 6-year-old language. 10 years old, we can speak a 10-year-old language. Teenagers will speak a teenager language, but they all understand. Your kids are smarter than you think. They really can get it. Their parents are worried. So we encourage them to know, because when you don't tell them things right, and they start imagining, humans are all like that. We always imagine the worst possible thing ever. Or they go and Google. Right, Google, and then get some information that will scare themselves. So we will actually facilitate this kind of conversations so that in doing so, right, we hope that the family can actually take this time also to get closer together. So a lot of times, right, I always use illustration with family members. They always love each other, they want to protect each other. So they cry on their own, back to back. Very far away, right? But if you turn and face each other, right, if this person starts crying and your loved one sees you, naturally they will just move towards you and they will just hug you, hold you, and you get closer already. So that's why we always encourage that kind of communication between family members. Okay? And finally, we also tap on our community partners, because we can't do the job on our own. Okay, we have very, very good community partners who actually help support the needs of the cancer patients psycho-emotionally as well. And I think a good point to be made is that this is not just the work of social workers. The entire healthcare team actually is very psychosocial, and they're very mindful of things like that. And we work very closely to talk to each other and to highlight needs of the patients. Okay? So in short, these are the many, many things that we do. Okay, it's a lot of things, and we just meet whatever needs that come up. Okay, whatever we cannot do, we'll refer you all to the right people to make sure that it's met. Okay, and how to connect with us? This is where you can actually get a referral from your doctor, but we can only support the patients who are in NUH, sorry. Yeah, but every healthcare institutions have their own social workers as well, so do reach out through your doctors. Okay, no, because we cannot use their hospital's money, so we can use our own. Okay, so reach out to us, get a referral through your doctors, or even any nurses. So not just doctors, any nurses that they know they are worried, they can also make an appointment for you to see us, or you can walk into our departments over at NUH. Okay. So finally, just a last note to people who are actually struggling with cancer or supporting someone. This quote that I saw, just to encourage everybody, keep walking, keep running. Let cancer be the shadow that disappears when life turns a new day. Remember that cancer, yes, is a big thing, but it's only a part of your life. You are still a father, a son, a husband, a boyfriend, a friend, a mother, a sister, a friend. Other roles that you are still playing, besides just cancer. So getting the support helps us make cancer not take over your entire life, but just a part of it. Okay? Thank you very much. We'll answer questions later.
Now, let us welcome our second speaker of this morning, Dr. Yong Woon Chai. She's the Senior Consultant with the Division of Palliative Care at ANSYS. Dr. Yong is also a Head and Senior Consultant with the Supportive and Palliative Care Program at Alexandra Hospital. She's the Assistant Professor with the Yong Lulin School of Medicine, and she'll speak about palliative care makes your life long and better, the role of partnership. Let's welcome Dr. Yong.
Hey, hi, thank you everyone for coming today. Maybe just a little bit of background on the palliative care service on the Western sector. So basically under NUHS. So some of you may wonder, why am I a head and senior consultant at Alexandra Hospital and then I'm still a member of ANSYS? So what happened is that since they reorganized the healthcare cluster, I think in the late, around 2016, 2017, so that time they were building the new Alexandra Hospital. Previously, it was used to be nesting hospital for Sengkang Hospital and Ng Teng Fong Hospital. So now a new hospital is being built. So they wanted to reframe and relook into the organization of the services. So decided then NUH to branch out to Alexandra Hospital. So therefore, I was sent from NUH to Alexandra Hospital to build the palliative care department there. And why is that so? NUH is currently quite saturated with the services. It's been built for many, many years with many, many robust services that's already running. So to focus on any new area, they are looking at new space, new blood, and therefore a new area of development. So therefore, I'm there. I'm across both sides, serving both Alexandra Hospital and NUH. Okay. Second thing, you may also notice that the slide is a little bit different as compared to what that was listed. So originally, when Dr. Lim Siu Ing asked me to speak on today's talk, she said, okay, you talk about palliative care. I said, okay, fine. So, and then when I received the title says, palliative care make you live longer and better, the role of a palliative care doctor. So when I look at that, I go like, alamak, the role of a palliative care doctor. It should be, for example, if you have children, your children go to tuition, right? So your children go to school. So it is not just about, like you just perhaps can view me as the teacher. So it is not just the teacher that is important. More importantly, is actually the student and the environment that is supporting the student to do well in school. So therefore, I think that partnership is important for everyone, including in this cancer journey. Okay. Okay, so let us start to talk about palliative care. So palliative care is actually like an approach. So what does it mean? The word palliative care actually came from the word palliare. It means to clothe, to have an extra layer of clothing to be covering the person. The second part is about the word care. The care is about a process of protecting someone or something by providing that person something that the person needs. It is not just palliative care. Palliative care is also a branch of medicine that provides science of dealing with health and preservation of health. So this definition is taken from WHO. So it's basically an approach that improves the quality of life of patients and the families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether it is physical, psychosocial, or spiritual. So this is another slide that's taken from WHO. It improved the quality of life of patients and the family. Early delivery of palliative care reduces unnecessary hospital admissions and the use of health services And it involves a range of services provided by different and a team of professionals, including the aspect of biopsychosocial. So here, I think that people also often ask what is palliative care and what is hospice or end of life. So palliative care in the past used to model very differently, that often palliative care get activated or involved only during the very late phase of patient's life. But there are more and more evidence that actually shows that early palliative care actually helps with patients the minute when the patient is diagnosed with a life-threatening illness. Okay. So palliative care is not exactly the same as hospice care or just purely end-of-life care. So palliative care, it can be applied much earlier, whereas hospice care of end-of-life care typically refer to a fairly late phase of the illness or the trajectory of the patient. And in US, it's probably used more for insurance purpose rather than for practical purpose. I mean, rather than the way that we use it in Singapore. So just now I've talked about what is palliative care. Now maybe we can talk about who provides palliative care. So palliative care comprises of biopsychosocial aspects. So therefore, we will need a team of professionals that look into the biopsychosocial aspect. So who do we have? We usually engages, I mean, you are very familiar with the doctor and the nurses. And we also work with allied health, with physiotherapists, occupational therapists, speech therapists, dietitian pharmacists, social worker. We work very closely with Tarina and her team. And we also work with other professionals like chaplain, advanced care planning facilitator, and in some setting, we may have people that work in the area of music therapy, art therapy, and pet therapy. Okay, unfortunately, music therapy, art therapy, pet therapy is very hard to be administered in the hospital, so it's not available in NUH, but in some other setting, like for example, Dover Park Hospice or RCC Inpatient Hospice, they may have some of these services available. So then again, palliative care is not just one thing, it's also the whole range of things that we do. So when we say about biopsychosocial, what does it mean? What do we do? So for bio part, we look after the patient's symptoms. For example, if the patient have pain, breathlessness, fatigue, sleep problem, nausea, constipation. Emotional aspect, anxiety, depression, confusion, hallucination. Sometimes we help people deal and process their grief and the situation that they are facing so they can make better choices. And we help with advanced care planning to decide with regards to what is needed, say, for the next few weeks, months, or years to come, what kind of care need to support this patient at home. Counseling, financial aspect, and then in Singapore, the hospital setting is a little bit limited in the sense that we don't have dedicated spiritual care except for some of the community hospital and the hospices that offer chaplaincy, spiritual care. In US, overseas, Canada, and all this, some hospital, they may have chaplain in-house. So we also help with caregiver training, education, prognostication, and communication. Prognostication in a way is important in terms of not just the lifespan, but in terms of many aspects, like for example, function. Whether we think that the disease is going to affect the patient in a certain way, and then the patient might not be able to get back to the job, and how can the patient function, to what level of capacity. Or sometimes it may has to do with time frame. For example, this may affect resources that is being tied in with that. For example, do I hire a maid, or do I not hire a maid because the time is too short? Or do I call my children from overseas to come back to visit me at this time, and they can't just keep flying back all the time? You know, this kind of thing. And communication. So the next few slides, we will share about what our experience says and what the research paper actually says. So maybe just let me share a story with you. So I have worked with Mr. Lam for quite a while. When I first saw him, he was transferred from another hospital to NUH, and he had surgery at another hospital, very aggressive surgery for his esophagus cancer. And when he first had the surgery, everything went well, and then he thought that, well, he's gonna do fine. But the cancer came back very, very quickly, and he had a lot of side effects from the treatment, from the surgery itself, and he had a lot of regurgitation. And when the cancer came back very quickly, and it gave him a lot of pain. So he was referred to me when he was having pain crisis. So we were seeing him, helping him with his pain at some point, and then he also couldn't eat, and then he had a feeding tube, and we were trying to feed him with feeding tube, but even then the reflux was very, very bad. So he stayed for a while. We both him and the family and us thought that he may not do well, but he went through cancer treatment as inpatient, fought through, and then he went home better. His pain was controlled. He was able to slowly regain his function. So initially I referred him to home hospice. After some time he was doing so well that the home hospice actually discharged him. And until now, I think it's about 4 to 5 years now, after his cancer, he's still seeing me in the clinic. He is, I mean, the upfront presentation was a metastatic cancer. Right now, the cancer is minimal. I still think it is metastatic, although we couldn't really prove it on scan. But I think it's more like an animal that's being tamed and caged now. So he is now carrying on his life as well as possible. So we work together with the oncologist. So it doesn't mean that I can achieve that everyone, but it depends on the kind of setting, the kind of response that they have with the cancer, and what is my goal. My goal then was mainly to help him with his pain, to help him adapt back home, to help him carry on with the treatment and what that was required at home, and see how things go. Yeah, and he knows that when he has problem, he knows where to come back and who to look for. So we talk about what our experience says, and then just wanted to share with you about one of the many studies that was done. So this study was, why I picked this study is because it was a landmark paper that was done by the Harvard group by Mass Gen. So this study recruited a number of patients with lung cancer, metastatic upfront, so randomized them to palliative care versus standard oncology, meaning no palliative care. So palliative, so you can see that the palliative care include the palliative care consult plus standard oncology. So what does it mean? The patient receive additional work on pain and symptom management, psycho-spiritual support, assist in treatment choices, and community care. And after that, it was bereavement support. So the result of this study showed that palliative care, early palliative care involvement, so meaning that the minute when the patient diagnosed to have metastatic lung cancer, randomized to cancer treatment, palliative care plus cancer treatment, the arm with palliative care plus cancer treatment has shown improvement in quality of life and mood in terms of the depressive symptoms. And the second part shows that the care was, the treatment was less aggressive, but the survival was slightly longer in the palliative care arm. Okay, so what we were trying to, so what we often experience is that for patient with cancer, it doesn't always mean that aggressive care means longer survival. It actually means doing the right thing at the right time will result in longer survival and probably better quality of life. Okay? So besides the previous landmark paper that was published by the Harvard group, and then ESCO guideline actually shares that they recommend integration of palliative care early into the standard oncology care. So ESCO recommends, ESCO group has actually looked at this and then find that palliative care improve various outcomes, including symptoms, quality of life, better prognostic understanding, mood, end-of-life outcome, resource utilization, and maybe survival. Okay. So it's been shown in various randomized controlled trials. So they recommend early integration of palliative care together with oncology. Okay, I'm a very practical person. So now I'm talking about limitations. So limitation is that I have talked about palliative care. Perhaps until now, some of you may still think that it's very vague. You don't really understand what this is all about. It is complex because it is multi-pronged, multi-domain. That's not just one thing. Like the patient take this one drug and improve the outcome. Palliative care is not like this. Okay. The other thing is that some of the studies, although it shows longer survival, it is secondary analysis. So the intention of the study is not set up to study for longer survival. They just they just conduct the research, and it's a by the way kind of thing that they found, oh, it improves survival. Okay, although very often it is proven that it actually shows that it improves quality of life and it improves the resource utilization. So the practical constraint. The practical constraint is that palliative care, as you can see, because it's multiple domains with many, many teams involved, so therefore it is a very high-touch, low-tech aspect, and it is then resource-intensive. It's not like me giving a drug. I can give 10 drugs, no problem. It's not a limitation. But if you ask me to send 10 different teams of people to go and see you, it is going to be very difficult, right? Okay. So, and it also requires a specific type of training, skill set, as well as time to be able to attend to the patient and the family. So there is also a question in some of the studies that we're looking at what type of patient group, where, when, was it from early of diagnosis or is it a little bit later? Okay, so in general, it is encouraged that earlier palliative care is good. But in practice, there are not so many trained staff to be able to cope with the recommendation. So therefore, there is actually practical constraint. But I would still say that if the patient has got symptoms, please don't wait. If there are a lot of dilemmas, if the patient is not getting better with treatment, and you need some advice, please look for us. So then, it is about a partnership, a journey. So we are pacing together, looking at hopefully be able to provide the patient with a more peaceful environment to cushion the impact and to cushion the harsh weather, okay, and to be able to provide some symptoms control. So does it really help patient to live longer? For the correct patient group, yes, but I can't say that I'm gonna be able to do this for everyone. It's just like, would the child be able to always do well in the exam, even if you give them a good teacher? I mean, it really depends on various factors that's involved in that child, okay? Does it really help people to live better? I would believe so. So this is the last slide. So I just wanted to point you towards Singapore Hospice Council, which is a public fronting organization that provide resources for palliative care. So if you want to know a little bit more, you can go to Singapore Hospice Council to look at some of the information there. Okay, thank you very much. I'll take questions later.
Now let's welcome back Dr. Yvonne Ang, consultant with the Department of Hematology Oncology, insists to share with us about the topic, what is a clinical trial and is it right for me? Let's welcome again Dr. Ang.
Cool. Hi, it's me again. Let me just wait for my slides to come up. Okay, thank you. So you've heard the sharing from my colleagues, and I must say that, as a medical oncologist, we do work very closely with the palliative team as well as the medical social workers, and they're absolutely invaluable in patient care. So I hope that, their talks have given you, a good overview of the sort of things that they do. So now I'd just like to move on to talking about clinical trials. So clinical trials, I feel, is a little bit of a black box to many people. You know the word clinical trials, but there's not a lot, some people don't really have so much of an understanding about what that really entails. So I'm hoping today to talk a little bit about that. So when I propose a clinical trial to a patient, say, might want to consider, there's this standard treatment, but there may also be this clinical trial option. Most of the time, I'm met with quite worried looks. Like, you want me to go for a clinical trial? And that's led me to to understand that patients do have many concerns when they are confronted with the idea of going for a trial. Yeah, I apologize. Yeah, so what are some of the things that people think of when talking about clinical trials? I don't want to do a trial, they're going to do experiments on me. It must mean that I have no hope, that's why they're asking me to do trial, because there's no other option. This is my last resort. I don't think I want to, because all these new medicines are going to have a lot of side effects. If the cancer doesn't kill me, the trial medicine may very well kill me. And anyway, it's not going to work. So why you ask me to go for a trial? And the one that I hear most often, I don't want to be a lab rat. 我不要当白老鼠. 为什么你给我这种药? Why are you giving me medicine that, isn't even proven in humans? So these are very valid concerns. I don't say this to put down any of these concerns because they are very real. But I think what I would like to do today is to talk a bit about it so that we can dispel some of the myths and some of the misunderstandings around clinical trials so that you can approach it with a more informed view as to whether or not this is something that might be suitable for you. Okay, so this is what I'll talk about today. What is a clinical trial? Different types of clinical trials. What are some of the things that you should be thinking about and that your doctor may be thinking about when recommending for a clinical trial for you? I'm going to talk a bit more about the support and the system that we have in place for running clinical trials at NCIS. And I'm also going to be talking about some of our specific trial as well as patient examples that we've had. Okay. So basically, evidence-based medicine. Why are trials important? So how do doctors decide what treatment is best for you? We actually use this principle called evidence-based medicine. So evidence-based medicine involves using what we know from research, so the best available research evidence for something, but we also then bring in our clinical expertise as to how this research evidence might apply to an individual patient, and we would also tie in what the patient's values are, so what is important to a patient. So that's how we, decide what is the best kind of treatment to offer. So clinical trials is a very important part of this because basically where the best research evidence comes from is from doing clinical trials to understand what the best kind of treatment might be in a particular individual or a group of patients. So what is a clinical trial? A clinical trial is a research study that is conducted in humans that has the aim of answering a specific question about a person's health. So this specific question can be something related to treatment or a new device. What kind of dose should we be using? Does this treatment even work? What are the kind of side effects that we can see? Are there new uses for existing treatments? So novel combinations, novel uses for these treatments. Clinical trials can also be done for the purposes of diagnosis or screening. So what are the best kinds of tests that are done? Who should they be done in? How often should they be done? These are all the kinds of questions that we would be looking at. One thing that I want to make very clear very early on is clinical trials are always voluntary. So we would never force someone to join a clinical trial. If it is suitable, we might offer it to a person, but it is always voluntary. And even if you do join a clinical trial, at any time, if you don't feel comfortable or you don't want to continue in it, you can always withdraw. Okay, so So clinical trials have many phases, and this ranges from very early studies, from when the drug is just new and we're just starting to test it out in humans, all the way to after the drug has been approved. So we have phase 1 studies. Phase 1 studies focus not so much on whether the medicine works yet, but first of all establishing what is the kind of dose that is safe to give in humans. Is this medicine really safe? So this is normally done in very small numbers of patients, about 15 to 50 patients, and usually only a few patients are given this medicine at a time to see whether or not they're tolerating it before more people are exposed to the medicine. The trials then often move on to phase 2, which is where we look a bit more at the effectiveness of the medicine in more patients, and then to phase 3, where a treatment is compared against standard treatments to see if this new treatment might actually be better and become the new standard of care, and that's usually in hundreds of patients. Even after a medicine is approved, patients, we still do run trials, considered phase 4 trials, to collect the information of the patients who are already on an approved medicine to look at the long-term side effects. So why should you join a clinical trial, or why should you consider joining a clinical trial? So there are multiple reasons. First of all, the clinical trial might be an opportunity to try a new treatment that is not yet available commercially, not yet available to you, but yet may have a good chance of helping to control your disease. This can sometimes be a completely new treatment, or sometimes it can be an existing treatment that has been repurposed in some way. So either as a new combination, which I'll talk about some examples later, but either as a new combination or possibly in a new kind of cancer, like it's approved in other cancers, but we're trying to see whether or not it would also be effective in your cancer. Sometimes we do clinical trials because it's an opportunity for our patients to see in our patients whether or not they can be given a lower dose of a medicine that might have the same benefits as a higher dose, but perhaps lower side effects or lower cost. So we do have some such clinical trials running at NCIS. So for instance, we have a trial of a very common medicine that we use in lung cancer. So patients are supposed to take this medication once a day, but we're currently doing a trial to see whether or not if they take it once every other day, whether or not actually they do just as well as the people who take it once a day, but with less side effects. And of course, the less medicine you take, the cheaper it is as well. So you're not always necessarily looking for a better treatment in terms of outcome, in terms of cancer control, but other benefits can come about from clinical trials as well. Of course, in joining a clinical trial, you would be helping us to further our knowledge of cancer treatment, and this would help to to further cancer patients in the future. The other thing is that clinical trial medications are usually, although not always, covered. Like the cost of them is covered by the clinical trial. So why are clinical trials important? So it's actually through clinical trials that we have started to understand that cancer is really not a single disease. We no longer just look at a person and say, okay, you have lung cancer, you have breast cancer. Breast cancer is treated like this, lung cancer is treated like this. These are our only options. Now we have actually come to realize that cancer is actually a whole group of quite different diseases, and it's very important for us to find out exactly what is driving a person's cancer in order to treat them. So what's shown on the slide here is really an example from lung cancer. So instead of lung cancer being one disease, if you look at the pie chart, lung cancer can be split into so many different subcategories. Basically, what we know now is that in certain types of lung cancer, the cancer cell growth is driven by gene changes. So there are changes in the genes, in the molecular type of the cancer, which then helps the cancer cell to grow. And if we then identify what these gene changes in the cancer are, we can then use targeted therapy against that gene change. So that list there, there's a long list of medicine on the slide, but basically there are 8 or 9 genes now that have been identified in lung cancer, and each of them has approved targeted therapies against them. So cancer treatment is no longer one size fits all. Cancer, go for chemotherapy. Actually, there are many patients who are actually suitable for targeted therapy, and it's very important for us through clinical trials to have developed this knowledge and to continue to develop the drugs that can target each particular individual type of cancer. So this is what we aim to do in NCIS. Generally, when a person is diagnosed with cancer, We discuss them at a multidisciplinary tumor board, and we also determine if molecular profiling, that means doing this sort of gene testing to look for targets, is right for that person. If the result comes out and there is a target, then we would have this discussions again at our tumor board to try to match patients to the appropriate treatment. Some of these targeted treatments are already readily available. Sometimes, if patients have certain targets, they may also be good candidates for clinical trials. And so what we try to do is we try to use these molecular profiling results to match patients to appropriate clinical trials. What we have at NCIS to help with this is actually our IMAC program. Excuse me. So this is the Integrated Molecular Analysis of Cancer program. And what happens within this is basically that a patient who undergoes molecular profiling, so who has cancer, would undergo this sort of gene test to see on a whole panel of genes to see whether or not there are any changes or any mutations in these genes that can potentially be targeted. When the results come out, we hold a molecular tumor board once a week. So all the people, so the doctors get together and sit down and review the results to make a recommendation as to what kind of therapy the person might benefit from. Sometimes this is standard therapy, but sometimes this is also clinical trial therapy. So we started doing this program about 10 years ago. So in the initial pilot phase, the test that we were doing looked at about 50 different genes to look for these gene changes and then to match patients to clinical trials. And what they actually found over the first pilot period, of the 300 patients who went for this sort of testing, about 8% of them managed to be matched onto appropriate targeted agent clinical trials. And of these patients who were on targeted clinical trials, the what we call the clinical benefit rate, that means the chance of the cancer being controlled for a period of time, was about 45%. So this showed us that using this sort of gene testing to try to identify patients for trials could potentially benefit patients and control their disease for a period of time. So what are some reasons that you might consider going for a clinical trial? So a clinical trial would be, your tumor, some reasons that your doctor might actually recommend a clinical trial for you. So first of all, a doctor might recommend a clinical trial if you have actually been found to have one of these molecular alterations, so one of these gene changes for which there is a trial available and a good targeted agent that may actually help to control your disease. It is true that in some situations there are not necessarily anything to target, but we also have some general clinical trials which are also testing out new treatments that can be used in an all-comer population. That means patients with any tumor type without any particular targets. Sometimes if your remaining treatment options are limited, that is also sometimes a reason why your doctors may suggest a clinical trial for you. We also sometimes do clinical trials, as I mentioned earlier, when we believe that there may be a treatment option available that is just as good as a standard treatment, but with less side effects. One thing I do need to share about clinical trials is that we generally recommend clinical trials to people when a person's body is strong enough, when their organ function, their kidneys, their liver are all working well enough for us to consider a trial. Because of course, at the end of the day, these trials are often new medicines. They can sometimes have unexpected side effects, and we want to make sure that patients are strong enough to be able to withstand some of these side effects when they happen. Just a few other things that it's worthwhile to know about clinical trials. So clinical trials, generally, we have to try to do them as safely as we possibly can. So usually they define quite clearly the types of patients that they're looking for, and your doctor will need to check against the eligibility criteria to see whether or not you are suitable to join a clinical trial. A clinical trial, because they are using new medicines, again, we have to be quite careful in terms of monitoring. So there's also a very strict schedule to be adhered to with regards to the schedule of the treatment, the schedule of doing any blood tests and scans and other investigations. So a clinical trial is a commitment in terms of time, and it's quite important to adhere to this strictly so that it's given in as safe a manner as possible. Unexpected or expected side effects do occur, so again, something that we do have to watch very closely for. Trial medicine doesn't always work. I'll be sharing some examples from our experiences with patients on clinical trials, and of course, I will be sharing largely positive examples. But as with any cancer treatment, it's not always the case that a clinical trial will work. And so what we do is to scan patients at regular intervals to see whether or not the trial medicine is working, so that if it's not, we can stop it and consider further treatment if there is any available. As I mentioned earlier, clinical trials are voluntary and you can withdraw your consent at any time. So just moving forward a little bit from the personal perspective to a little bit about the kind of support and infrastructure that we have available at NCIS for the running of clinical trials. So we're quite fortunate at NCIS that there's a whole group of people working together in making these clinical trials a reality. So we have very close collaborations with many laboratories at the Cancer Science Institute. So this brings so that experimental techniques or new drugs that may be formulated in the Cancer Science Institute can then be translated into a clinical trial. We also have we also have many other support systems that are available, which I'll go into in a little bit more detail. So just to summarize a little bit about our current clinical trials. So generally, we target to have 200 active clinical trials open at any one time. And this focuses on early phase 1 studies. So we focus especially on new therapies and in smaller populations of patients. We focus on immunotherapy trials. So generally, so for instance, in the year 2022, we had a total of 276 trials open, recruiting a total of about 265 patients for therapeutic, that means new drug treatment-related clinical trials, and another 3,000 patients who were recruited for what we call non-therapeutic studies. So non-therapeutic studies are where we collect patients' blood or personal, the data about their cancer and their treatment for us to learn a bit more about these patients, but not necessarily administering new treatments to them. So as I mentioned, we do focus on phase 1 clinical trials, particularly first-in-class or first-in-man trials. So these are very new drugs that have not been tested very much in the past. And we run about 100 of these trials at any one time. We also focus on immunotherapy trials. So I think a lot of you will have heard a bit about immunotherapy in the news, but basically it's different from conventional chemotherapy, which is toxic medicine that goes into your body to kill the cancer cells. How immunotherapy works is that it changes the immune system in some way to help the immune system to better target the cancer cells to control the cancer. So we do focus on these trials as well. There are many different kinds of immunotherapy, but we have about 125 of these trials open. So as I mentioned earlier, we're very fortunate to have the support of many different groups of people. It's certainly not just the doctors who are performing the trials. I mentioned the Cancer Science Institute. We also have the Hematology Oncology Research Group. So that's comprised of the medical unit, which is the doctors, the pharmacists, but also the clinical trial unit. So very important people include the study coordinators. So the study coordinators are actually the ones who really walk through the trial with the patients, are often available as a point of contact if patients have any questions about the clinical trial. There's also a group of administrators who helps to support the running of these trials, because as you can imagine, logistically, to have so many hundreds of trials running, it is quite a big endeavor. Within NCIS and within the doctors, there is the Developmental Therapeutics Unit. So it's a group of about 10 doctors who specialize in running phase 1 clinical trials. Phase 1 clinical trials are quite unique in the sense that these are really new drugs. And we often don't know what the effect is going to be on people. So as I mentioned earlier, we start low, we give it slowly, we only try it out on a few people at once, and it does take a level of expertise to be able to do this. So we're fortunate to have about 10 phase 1 doctors who run a special phase 1 clinic, specifically for patients who are on phase 1 clinical trials or considering joining phase 1 clinical trials. We also have dedicated facilities for these clinical trials, so including dedicated areas for drug dispensing, dedicated chemotherapy chairs that are ring-fenced for people on clinical trials, and even interview rooms for patients for counselling, and where the study coordinators can explain clinical trials to these patients. We do give out, so there is this phase 1 booklet which we give out to patients who are considering phase 1 trials to give them a bit more understanding of what they're considering joining. So aside from all these things that I've mentioned, I spoke earlier about the fact that clinical trials sometimes have unexpected side effects. So immunotherapy side effects are something that you sometimes need a group of more specialized organ specialists to deal with. So we actually have a team in NUH of organ specialists from the various departments and divisions who are interested in immune-mediated diseases. So they can be contacted to perform a rapid evaluation of patients who are suspected to have any immunotherapy-related adverse events. So we work together with them to design certain algorithms, so certain pathways of what we should be doing when a patient comes in with a side effect that could be related to some of their clinical trial medication. Okay, so now I just move on to the last bit of my talk, which is to share with you guys a little bit about some of the experiences that we've had with clinical trials and some of our patient success stories, so to speak. So I mentioned earlier, that clinical trials often first start in the lab, and we are fortunate to have this pipeline of people doing basic science research in CSI, and then this can sometimes be even translated to clinical practice. So this drug, lenvatinib, is actually an oral anti-cancer drug that is already approved in thyroid and liver cancer, but it has not been tested in breast cancer before. So in breast cancer, a certain kind of breast cancer called hormone-positive breast cancer, our standard treatment is to give hormonal therapy, sometimes in combination with some other approved therapies. But what they found in the lab in CSI was they were testing breast cancer cells, so not actual patients, but just in the cells. And they were testing an anti-hormone agent. They tested this new treatment, lenvatinib, and they tested the combination between the two. And what they found was that each agent alone managed to kill some of the cancer cells. But when you use an anti-hormone agent together with lenvatinib, it actually managed to kill even more of the cancer cells. So they worked together to improve the cell killing. So because of that, there was this clinical question that if we were to give an anti-hormone agent, such as letrozole, which is commonly used in the clinic, and we added on this lenvatinib treatment, would this be able to give us good disease control in our breast cancer patients? And it actually did. So we found from this study that giving lenvatinib together with letrozole was actually effective in controlling breast cancer. In more than 50% of patients who were put on this trial, they actually had either stable disease, so their cancer did not grow for more than 6 months, or even in 32% of patients, significant shrinkage of the tumor. So this work was actually published in a journal, in a cancer journal, and is a combination that we are continuing to explore further. So it just shows that although these are new combinations, it doesn't necessarily mean they don't work, and there is and it is something worth considering because some of our patients have truly benefited from this. To give some individual patient examples from this trial. So for instance, this patient, she had stage 4 breast cancer. So it was breast cancer that had spread to the liver, lymph nodes, spleen, and bone. So I'm not sure if you can see, so these like darkish spots in her liver on her scan. And she had these spots despite having chemotherapy in the past. So she was started on this combination on the trial of letrozole and lenvatinib. And you can see by June 2018 that the liver spots are barely visible. So they're much smaller than they were previously. And up to 4.5 years later, there was actually minimal disease left in her liver. So this treatment actually controlled her disease for an additional 4.5 years. Another patient who also had stage 4 breast cancer that affected the lungs and the lymph nodes. So she had quite a lot of treatment before. She had the first hormone therapy for almost 4 years, a second hormone therapy for almost 3 years, and then when the drug was no longer working, she tried a third hormone therapy in combination with another medicine. So this is one of the standard treatments. That one didn't work so well. After about 3 months, her cancer was starting to grow again. So we had some choices at that point. Should we start her just on standard chemotherapy, or can we actually consider her for this letrozole and lenvatinib trial? So she went on the trial, and so this is a CT scan of the lung. It's a cross-section. This is the right side, this is the left side. And you can see that there's this lump in the right side of the lungs, which represents the disease that she had. So June 2018, so she took the medicine, and the disease shrunk nicely to the point that even in March 2022, again almost 4 years later, the disease was still much smaller and well under control. So just to share a few other examples. So we've spoken about clinical trials sometimes originating with ideas that were formed in the lab and then coming to clinic. We also talked earlier about how we try to match our patients' gene changes to the kind of trial treatment that we have. So we have a study ongoing actually called the Tapestry study, where we do this sort of gene testing, and then we assign patients to treatment depending on what the gene testing shows, based on the identified gene changes that they have. So this patient was just recently started on treatment. This gentleman with metastatic thyroid cancer, he had previously had other treatment for this, but he went for gene testing and it found that he had this thing called a RET mutation, so a change in the RET gene. So he was enrolled on this study and he received pralsetinib on this study, which is a special oral drug that targets RET. So you can see, so he just started the drug in August 2023. This is a scan from July 2023, and you can see in his lungs, where the lungs are all expected to be black. There are multiple, so many that you can't count, white spots in the lungs. And just less than 2 months later, in September, after starting this drug in August, you can see that there are still these white spots, but they are so much improved compared to just 6 weeks ago. The other things in clinical trials is that patients do sometimes really have the opportunity to get treatment that is extremely effective and becomes the new standard of care. So the CROWN study was a study that, it was an international study, recruiting hundreds of patients all across the world. But our center was also involved with this. I apologize, the dates are a bit wrong. It did start earlier than 2017. But basically, in patients with a certain kind of lung cancer called ALK lung cancer, the standard treatment is to take a certain tablet. And what this trial was doing was it was testing out a new tablet against ALK versus the old standard. So we had a number of patients who enrolled in this trial, and this is one of the patients who, at the start, so this was in March 2016 when she first started this drug. At the moment, now it's called lorlatinib, but at that time it was just a drug just a drug being studied. It just had a long number name, and she was started on it in March 2016. So this is the lump in the lungs. So this is her latest scan that was done in September or October of this year. She's still on this medication and her disease remains under control, still hasn't returned. So, she's been on this drug all this time. She started out on this drug when we didn't know whether it was a good drug. We didn't know whether or not she would manage the side effects. And now, 7 years later, she's still on the drug. Cancer is still under control. And actually, this is the drug that we now prescribe to people as one of the choices that we prescribe to people as the standard treatment for this kind of cancer. So there is really the opportunity to access some of these drugs early. Of course, drugs are not always without side effects. So she does have some high cholesterol because of this drug, but we do manage it using medication. So I'm coming to the end of my talk, but basically just wanted to, I hope that this talk has kind of shown you that clinical trials are an opportunity to use sometimes quite promising treatment. That in NCIS we have had, we've been fortunate to see some new ideas and things that have been developed from early stages, in the labs, or novel treatments, new drugs, actually translate to impacting our clinical practice. So these are just some articles from the newspapers that that have resulted from some of these clinical trials. And through all of this, we hope to improve patient outcomes as well as experiences. Okay, just some of the other papers that we've had. All right, thank you very much.